Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Today I'm going to share with all my doctors, house officer, junior medical officer, about management of chest trauma. Okay, it's more towards the emergency conditions. I will actually focus on the indications of inserting chest tube, the indications of performing tube thoracostomy or open thoracotomy. Okay. When you receive patient at emergency department, basically patient presented with chest discomfort, tachypnea, abnormal movement of the lungs, you have to exclude tension pneumothorax. That is done in primary survey. So, an indication to insert chest tube in emergency department is only for life-threatening conditions, and it is tension pneumothorax. These are the only procedures you can insert chest tube without waiting for the chest X-ray. Just by clinical examination, distension one side of the chest, then hyperresonant on percussions, and reduce air entry or absence of air entry, that can be diagnosed clinically. So the management is actually can be done by needle thoracocentesis. Just inserting the needle at the second intercostal space to release the air, reduce the tensions. Why we need to insert chest tube or doing needle thoracocentesis in tension pneumothorax, and why it can cause death, immediate death? Because when you have leak of air into the pleural space, and there is no exit, so there will increase pressure in the intrathoracic. As a result, it will push the trachea, mediastinal organ to the contralateral side. And what will happen? Because of that, there will be reduced venous return, and as a result, reduced cardiac output. And this will result in hypotension, and subsequently patient can die if you don't intervene this immediately. Okay, that is the why we need to insert needle thoracocentesis and subsequently chest tube at emergency department, because you can save lives. But other than that, you can buy time, and most of the patient is all the other pneumothorax, which is about 30%, 50%, they can be treated properly after you admit the patient to the ward and do subsequent chest X-ray, because this can at least give you problem later in terms of medical legal implication, because chest tube is not without complications. Post-operative retained clots, post-operative and pneumothorax has been seen. Okay, so then after that, apart from that, we insert chest tube for pneumothorax or for hemothorax. Okay, now we go into the how we manage patient with chest injury which is unstable. Okay, when patient have chest injury with multiple ribs scenes on X-ray, for example, and then reduce air entry or hemothorax scenes, you insert the chest tube. Okay, if the chest, the drain, pneumothorax, you drain is more than 1,000 liter, that is one indication where you have to be alert whether this patient need to be sent to OT for thoracotomy or not. Second indication is the drain of blood by chest tube is more than 200 ml per hour for 3 consecutive hours or 4 consecutive hours. After the subsequent 1,000, then after that 200 for 3 consecutive hours. So this indicates there is active bleeding inside the lungs, active bleeding inside the thoracic cavities. So These are one of the indication of open thoracotomy in unstable patients. In unstable patients. In stable patients, you can buy time, means put the patient in the right place, ICU, and then perform CT scans with successful resuscitations. And then if you have enough available expertise, even general surgeon who have been doing VATS, video assisted thoracoscopy is one of the current management gold standard, in which you can identify the bleeding, you can clip, you can staple, you can suture. So that is indication for stable patients. But if you don't have that expertise, open thoracotomy and secure the bleedings. And bear in mind, 85% of the causes of continuous bleeding in hemothorax is from the vessels, either from the internal memory, thoracic, or from the intercostal vessels. And another 15% come from the lung parenchyma itself. So that means 85%, if you manage to, some of the vessels, if you can manage with just external drainage, it can be successful in, let's say, if it is not from the major vessel, it can be successful in 15-20%. Okay. And some center, if you are in the tertiary center, they can do intracatheter embolizations in stable patient. Radiological intervention can select the internal memory, intercostals, and they can embolize that. That usually done when patient have polytrauma, and associated with pelvic injury as well. So they want to embolize the pelvic vessels, they will embolize as well the lungs. Okay. Alright, so that is the pathway. So if you find patient unstable and then the initial drain of chest tube more than 1000 and subsequently 200 ml for 3 consecutive hours, you have to bear in mind this patient need to be sent to OT and explore. Alright, a little bit of VATS, even though it is not routinely done by a general surgeon in the district hospitals, actually is quite simple procedure where you at the side of chest tube or at the mid-axillary line 7 or 8 intercostal space, you can make an incision 1.5 centimeter like that, and then dissect and then introduce the scope. And this scope is usually 30-degree scopes. And another two 5mm part or 10mm part you can put at 30-degree angle, 4 to 6 inches from the scope, usually anteriorly, maybe at the 4 to 5 intercostal. Another one just next to the spine below the scapula, so we can just retrieve the clots or retrieve the thing or identify where the bleeding is. Okay, the problem is with the non-resolved pneumothorax. Non-resolved pneumothorax, which continuously bleed, is due to the presence of blood itself. Presence of blood and clot itself. This will trigger more and more bleeding because of the presence of fibrins and fibrinolysis. And this fibrinolysis process, they actually inhibit the presence of thromboxane A2, and then as a result platelet aggregation fail. So one of the modalities to stop this persistent retained clots, which further later on can give you problems such as infections and empyema thoracis. So they even advocate instill the fibrinolytic agent like streptokinase, like 250k, dilute in 100 ml, instill through the chest tube, and then position the patient in 1 hour and then try to clean it. This can be successful in 60 to 80% of patients. So clots in the lung, written clot in the lung is not good. So if it is happen within the 14 days, less than 14 days, you have to refer this case early to the cardiothoracic center, because they can do VATS and remove the clots. Because more than that, they already form adhesion to the pleura, and you need to do more like decortication, and that is difficult procedure and will lead to infections of the lungs. Okay, how we do thoracotomy, emergency thoracotomy? The best place is like 3 to 7 ribs, posterolateral, and then you ask anesthetist to give double lumen intubation, so that during the surgery you can always communicate with anesthetist to deflate or to stop inflate the affected lung, so that you can visualize the injuries properly. So intervention can be done either suture, staple, clipping, washout, and if there is clot, you can instill the saline and all those things. Okay, that's all about chest injuries. Remember, not all, tension, apart from tension pneumothorax, the rest of the pneumothorax and pneumothorax can be managed properly in the wards, because remember, chest tube itself can create complications, so you better prepare yourself with preliminary x-ray before you perform the chest tube, and then do under proper aseptic precautions. Open technique is better, and then depends on the type. If pneumothorax, you direct the chest tube towards upwards. If pneumothorax, direct chest tube towards inferiorly. If pneumothorax, you use bigger size of the tubes. 24 is small, you use 28, 32. You want to drain air, you can use size 18 or 24. Remember, I think in different slides, different video, I already mentioned about how you insert chest tube and remove. I think that's it. A bit about penetrating chest injury. Penetrating chest injury, even though the entry point is small, you have to be cautious, because it can penetrate vessel, lung, heart, and etc. So preliminary CT scan is required. Preliminary CT scan is required if you want to avoid explorations. So chest X-ray alone is not enough. So if you done CT scan and there is no solid organ injury and everything is okay, enough with chest tube if there is pneumothorax, all those things, and you can close the wound externally, because there is not only for chest, for abdomen as well, because people miss the injury to the visceral organs, because ultrasound chest X-ray is not adequate in managing the penetrating chest injuries. Or if you don't have this, you need to explore. Right? This is medical legal, and I hope all the junior doctors and all house officers benefit from this short discussion. Thank you. Assalamualaikum warahmatullahi wabarakatuh.